Hello everyone. We present a case of a rhegmatogenous retinal detachment in which no hyaloid separation was noted at the time of examination and in which past vitrectomy was required. After debulking the anterior vitreous, the hyaloid was stained with the help of triamcinolone. The supranasal atrophic primary break can be seen as well. The hyaloid was extremely adherent and difficult to remove due to the underlying retinal detachment. The vitrector, silicon tip cannula, and the island peeling forceps all failed initially. We kept persisting, strained the hyaloid multiple times, and kept attempting removal of the hyaloid. Attempts with the retinal finesse loop also proved futile. We then attempted to punch a hole in the posterior hyaloid nasally. However, this led to nitrogenic break. Further attempts at dissection of the hyaloid away from the retina with the help of PFCL or viscoelastic proved to be futile. This was so because vitroschisis had been achieved, but true separation of the hyaloid from the retina had not been achieved at any point at the retinal surface. At long last, the thick cobweb-like sheet of posterior hyaloid was lifted from the retina with serrated forceps, and vitrectomy could finally proceed. The hyaloid was also adherent to the break margins as well as anteriorly and had to be lifted away gently and cut slowly. A radial pigmented lattice was seen adjacent to the nasal break, and the hyaloid was extremely adherent at this point. Further attempts to lift the hyaloid away led to nitrogenic break. A fluid-fluid exchange was then done to reduce the motility of the retina and make separation of the hyaloid from the nitrogenic break easier. The anterior break margin was finally cut, the hyaloid separated, and an FX done to flatten the retina. Taking the abnormal adherence of the vitreous into consideration, additional vitreous base shaving was also performed under air. The brakes were then lasered and 14% C3F8 gas injected to satisfactorily conclude a tough and challenging case.